All right, Monica, whenever you're ready, I'll just keep letting people in.
Yeah, I'll kick off with our introductions here. And first off, just welcome everyone to the second annual Connecting Learning Healing virtual event. I'm Monica White, president of Colorado Tick-Borne Disease Awareness Association. And I'm so happy that we are partnered with the Colorado Lyme and Tick-Borne Disease Support Group to better serve the patient community in Colorado and beyond. I am joined today by Jody Foster and Joanne Schell as we co-host this May event. This weekend's event is sponsored by Agenix and is supported by our community partners that support our activities year-round. These community partners include Agenix, Sawyer Products, Technology, and Medical Bill Gurus. And we're so grateful for the support that they show to our organization to be able to carry out our mission. In addition, Sawyer has provided a door prize to one lucky registrant. This is a prevention package to help keep you safe in the outdoors, and we'll randomly select at the end of the two-day event and notify the winner. Sawyer will send that door prize to you directly. Our speakers today will present, followed by a Q&A session after each speaker. So please type your questions into the chat section, and we will do our best to cover all questions as time allows. If you have any problems maneuvering or dealing with the chat, you can also text your questions to Jody at her cell phone, which is 720-280-2341. And I do want to remind you that our doctors here today will not be able to answer personal questions regarding treatment. They can't provide medical advice individually over this process. Today, you will hear from both Dr. Kenneth Ligner and Dr. Joe Burrascano. And due to unforeseen circumstances, Dr. Jill Carnahan could not appear in person. So we will post a link to her pre-recorded presentation on the Meetup and website following the event. So with that, I would like to introduce our first speaker. Very happy to have Dr. Ligner back with us again, although not in person this year, virtually. He's a pioneer in the field of Lyme disease, and he'll be presenting today on disulfiram in the treatment of Lyme disease and Babesiosis, first 3 years experience in one medical practice. Dr. Ligner is a board-certified internist with additional training in pathology and critical care medicine, practicing in Pawling, New York. He has been actively involved in diagnosis and treatment of Lyme disease and related disorders since 1988. He has published multiple articles on Lyme disease in peer-reviewed scientific journals and has presented poster abstracts and talks at national and other international conferences on Lyme and other tick-borne diseases. He has additionally cared for many persons seriously ill with chronic and neurological Lyme disease. His work has focused on the serious morbidity and occasional mortality that can eventuate from this aspect of the illness. He has emphasized the urgent need for widespread clinical availability of improved methods of diagnostic testing and for the development of improved methods of treatment for Lyme disease in all of its stages. He holds the first United States patent issued proposing applications of acaricide to deer for area-wide control of deer tick populations as a means of reducing the incidence of Lyme disease. He has also co-authored in the Crucible of Lyme Disease, collected writings and associated materials. And you can find all of these references on our website. With that, I'd like to turn it over to Dr. Ligner. Again, he will present, and then we will have time for question and answer following his presentation. Thank you, Dr. Ligner, and welcome.
Thank you so much for inviting me, Monica and Joanne and Jody. I guess I gotta share my screen, right? So
yes.
See if I can successfully do that. And have to go to slideshow, right?
Yes.
I'm not very good at this. Okay.
You've got it.
We're good to go? Okay. So again, thank you for inviting me. And, you know, I was out there in what, 2018, right? You
Correct.
invited me out to Parker, which was, it's so gorgeous out there. You folks are so lucky to live and work out there. It's beautiful. In fact, after that conference, Dr. Rajadas and I took a little drive down, I forget the name of the canyon that leads to Red Rocks.
Yes.
The concert venue.
Yes.
and there was a concert that night. Unfortunately, we both had planes to catch, so we were very disappointed. We couldn't hang around. But anyway, the other thing. So I'm going to be talking about my experiences with disulfiram, and also, at the time that I was out there in Parker, you and I had a chance to talk a little bit about your case, and you were telling me about, 6 years before the MAST on IV antibiotics, something like that. And, I had just been working with disulfiram for about a year. And I was so tempted to talk to you about it, but I felt some scruples. Well, I wanted to talk to you about it, but then I also felt that it was like maybe not appropriate because it was so early, but I also felt a little bit bad that I didn't share that with you then, but anyway, here we are. So
it is helpful.
Yeah. So somewhere late in 2016, towards the end of the year, one of my patients brought to my attention, which I had not been aware of, that I guess it was the first of the Stephen and Alexandra Cohn Foundation Lyme Mine events at Mount Sinai, which at the time I didn't even know that it was happening. But one of my patients had been following Kim Lewis's work, and I guess he became aware that they had recorded the talks at that conference, which the conference that was October of, I think, 16. And they put it out on YouTube. So my patient saw Kim Lewis's talk, and he brought it to my attention. And there's a link to his talk there. So I watched his talk, and he gave the keynote speech. And towards the end of the keynote speech, he mentioned the work that had been done by Jayakumar Rajadas and Ravi Pothaneni, in which they had tried through high throughput, like they screened like a couple thousand substances that existed within the United States Pharmacopoeia, just randomly, to see what had activity against Borrelia in the test tube. And this is Dr. Pothaneni and Dr. Rajadas. And it turned out, surprisingly, unlikely, that of all the agents, near the very top was this drug called disulfiram, or tetraethylthiram disulfide, which is a drug that's been around, for like 50, 60, 70 years for the treatment of alcoholism. And so during that talk, actually it was in this sort of a amphitheater type lecture, I guess it was at Mount Sinai, and Kim Lewis starts talking about, well, we really should test this in mice, and see what kind of activity it has. And somebody in the audience, it was like an amphitheater type lecture, somebody in the audience, probably a physician, kind of raised their hand and said, well, why don't you just try in patients? And Dr. Lewis kind of shrugged his shoulders and said, well, that was that. And then, so anyway, I read the article, and then I read up a little bit on disulfiram. So the next thing, my patient says to me, after I had a chance to review everything, he says to me, hey, doc, could I try this stuff? So like I've said in other conferences, one big question is like, why would I agree to let him try this substance that had never been knowingly used to treat Lyme disease? And then, so by way of background, why I was willing to consider it is, my experience, and of course, many patients have had the same experience, but I was influenced by my experience with these tough, difficult cases where you treat and people get better, you stop treating, they relapse, you treat, they get better, they stop treating, they relapse. And it's very demoralizing and not very satisfactory. So this is some of the background of, why I got to that point where I was willing to consider it. This is a famous case of my patient, Vicki Logan. She was a patient that I started working with around 1989. She was a pediatric ICU nurse, as a matter of fact, and she had had developed a gait disturbance with a gait disturbance, and she had a chronic meningitis of unknown cause. She'd been seeing doctors and neurologists for several years before she came to me. She had a whole bunch of spinal taps, and she had this lymphocytic pleocytosis of unknown cause. And I studied her in great depth for about a year. And actually, I could not prove what she had. I used every test I had available to me, and I couldn't prove that she had Lyme. But I knew she grew up in a little hamlet called Golden's Bridge in Westchester County, which is a pond-side, wooded, tick-infested community, and that's where she grew up. She had no history of tick bite, no history of rash, and even though I studied her carefully, and I did not have any proof that she had Lyme, I also felt that, and also she was seen by everybody, neurologists, rheumatologists. Nobody knew what she had, and so finally I decided to admit her to hospital, did a spinal tap. Again, she had a meningitis. Treated her with 21 days of IV cefotaxime, which is one of the most potent intravenous agents. Tapped her after treating her for 3 weeks, and the spinal tap showed no change, and her condition really did not improve. And I treated her then for about 4 months, just for good measure, with minocycline. Again, had no impact. And then I figured, well, if she did have Lyme, I gave her the benefit of the doubt, and I just backed away. And then about a year later, her condition was continuing to deteriorate. She approached me and begged me for another spinal tap. So like I said before, you got to imagine how desperate people are to beg for a spinal tap. But the difference was, at that time, due to various circumstances, I had come to know folks at CDC Fort Collins, and they knew that I was seeing people who either did have Lyme or might have Lyme, because Westchester County at the time was burgeoning, and they decided to provide me with a limited supply of culture media, Barbara Stoner Kelly 2 culture media, which I happened to have at that time when she got back in touch with me in late 1991. So I did another tap on her, and this time I plunked a couple of cc's of her spinal fluid into Barbara Stoner Kelly 2 media and shipped it off to CDC. And a couple of weeks later, I got a very excited call from CDC Fort Collins, from David Dennis, that spirochetes were going from her spinal fluid. He was very excited and also somewhat disbelieving, because he knew that she had already been treated in a way that was supposed to cure Lyme disease. And yet spirochetes were growing out of her spinal fluid, which later were proven, well, let me just show this. Yeah, this was the title. And you'll see that folks from CDC Fort Collins, like just up the road a piece from where you are, right? Culture confirmed treatment failure of cefotaxime and minocycline in the case of Lyme meningoencephalomyelitis in the United States. And at the end of the day, the conclusion was culture of this CSF specimen in BSK2 yielded a strain of Borrelia burgdorferi. Culture confirmed treatment failures have been previously reported for 3 Lyme neuroborreliosis cases in Europe. The present case apparently is the first of this type to be reported from the United States. This made the front page of the Science Times, New York Times, in August of '93. And that's me at Vicki Logan's bedside. And you might notice, those of you who have a little medical background, she has a Babinski sign because she had spinal cord involvement. Anyway, and then that led to a guest commentary in the Journal of Clinical Microbiology. I love the quotation on the lower left-hand side. Disease is very old. Nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. And that was from Charcot of the Salpêtrière. And I can't see all of this, but yeah, and in that article, there was this statement: chronic persisting infection not yielding to antibiotic treatment presents a dilemma for the patient, the physician, and for insurance companies that are contractually obliged to pay for medically necessary treatment, or they should be. Of course, they found ways to avoid it. The solution is not denial of the reality of patient illness or imposition of arbitrary restrictions on allowable durations of treatment, but the design of more effective and less costly treatments that can keep patients well. Aside from prevention of the illness in the first place, methods achieving sure cure for those already infected must be developed. Antibiotics may not be the answer. Rather, application of new techniques of molecular biology to interfere irreversibly with key metabolic or reproductive processes of the bacterium, wherever it may be found in the body, including intracellular sites, may provide more effective targeted therapy in the future. So that's where I was coming from. That's why when my patient approached me, I was actually willing to consider it. So that first case, who I regard as, he's a true pioneer, because trust me, I never would have suggested this to any patient. It's only because this patient approached me and asked me if I would allow him to use it. And like, I never would have suggested it. He was a very well documented case. He'd been worked up by other people before he came to me. He had a couple of courses of IV, and again, he would get better, then he would get worse. And he had well documented Lyme as well as Vibisiosis. And so I designed a regimen of oral treatment with what I call industrial strength amoxicillin, like a really high dose, minocycline and Malarone. And he was on that for 7 years. And with that, his status was pretty good. It wasn't perfect, but he had a reasonable quality of life. He was able to work. He had a family, but he really didn't want to be on these drugs. And I can't blame him either. But whenever he did try to go off on a number of occasions, he would relapse. He'd be okay for a little while, and then he'd relapse. So very, very demoralizing. And yeah, he said to me, sometimes that he would stop, he would feel like jumping off a bridge. He was so disgusted that he couldn't get off the drugs. So that was the background. And so this is the first case that I know of. I have a feeling there probably have been people with Lyme disease who were treated with disulfiram, but nobody knew, either they didn't know that they had Lyme, or nobody had any clue that disulfiram would have any impact on it. But I have a feeling there probably were people who were unwittingly treated with disulfiram having Lyme and alcoholism, where they didn't know that. Anyway, he was the first knowingly treated patient. And of course, I didn't know how to treat him. I just picked the dose out of a hat. I checked out a little bit about disulfiram, what the usual dosages were for alcoholism. And I picked the high end of a customary dose. 500 is a little bit high. And, in dealing with antibiotics, many of us were so used to, dishing out 3 months at a time. So I gave him a 3-month supply, and I asked him to have surveillance labs, and he was very compliant. Every couple of weeks he had labs. They were fine. I told him to send me a note every couple of weeks to let me know how he was doing. He lived at a distance. Actually, he lived out near you, Joe, in the East End of Long Island. So it was not easy for him to get to my office. And he was very compliant. He sent me a note. He was doing fine. And then a couple months later, he leaves a message in my office voicemail declaring, canceling his follow-up and declaring, quote, "I'm cured." And furthermore, he mentioned in passing that he had required a hospitalization, but he didn't tell me why. So of course I was curious. I called him back up, and it turns out that he had required a psychiatric hospitalization. So that prompted me to do a little bit more research about disulfiram. And it turns out it is well known that occasionally disulfiram can cause emotional disturbance. It can affect neurotransmitters. So I got back to him and discussed that with him. And he said to me, "Hey, doc, I don't think it was the disulfiram." It turns out he was in the middle of a very, very stressful situation. And then he says to me, "But even if it was worth it. And don't fail to offer it to people just because of that," he admonished me. So meanwhile, he had not needed to come back to the office. When we touched base with him every couple of months. And at a recent contact, which was about 3 years, 8 months out, he was remaining, according to him, of course I didn't see him, but by his report, he was remaining clinically well off all therapy, which is like amazing. So so he was the first case, and I kind of couldn't believe it. With that experience, which was really amazing, I shared that experience with 1 or 2 other patients. Again, they were very well characterized patients, and they were also struggling and needed intensive treatment to remain well. So that was case one. Then case two, very, very well documented, actually retired physician with bulletproof central nervous system Lyme. He had like 10 spinal taps, all of them had selective intrathecal antibody synthesis. He had a lot of psychiatric issues that required very intensive psychiatric care, not by me because I'm not a psychiatrist, but he had an excellent psychiatrist, and he required very intensive treatment. He required ketamine infusions once a month because he had such dense depression. So anyway, I told him about case one. I spoke to his doctor, I spoke to a psychiatrist, and after giving it careful thought, and this guy required repeated IV, IV or IM ceftriaxone, it was tiresome, but that's what he needed. So he decided he was going to try it. Everybody was on board. So same situation. I gave him a 3-month supply of disulfide 500 milligrams a day, and he was retired. He lived alone, and he took the disulfide, but the first guy handled it pretty well. I mean, he was up and about, he was working. Second guy, the disulfide basically was, for him, very debilitating. He was basically confined to bed for the entire time because the effects were so profound on him. And then around the 6-week mark, he had to go for the hospital. So not even had anything to do with me, but he had to go to the hospital. And on his way there, he had a syncopal spell and hit his head, had a concussion actually, was admitted and then discharged. Luckily, nothing serious happened. And with that, his neurologist, not unreasonably, said, "You better stop that disulfide." And it turns out, in retrospect, some of the meds that he was on from a psychiatrist probably were synergistic and resulted in that syncopal episode. But anyway, I called him back up when I heard what happened, and he says to me, "I think your treatment worked." He remained well for a year. He was able to come off most all of the psychiatric meds, and he got back to what he regarded as essentially normal status for a 70-something-year-old gentleman, until he had another tick bite. And then the mid-level in his doctor's practice, instead of treating him right away with the doxy, he had no symptoms, so you want to wait till he has symptoms. So, so he was finally treated with doxy, and then actually got a further course of disulfide, not from me, but from a psychiatrist. And he's done well, actually. He had a shortened course of disulfide the second time. Anyway, so again, it was like dramatic. And this guy was sick, really sick, and very well documented. And so, 2 out of 2 is kind of amazing, So I mentioned to another patient, and this is a patient of mine. He's a police officer, been under my care for like 25 years, very well documented, Lyme and Vibisiosis. There were times that he could go off for a period of time, and then he would always relapse. He required very intensive oral, many different bouts of ceftriaxone, either IV or IM, Mepron, Malarone, because he had Babesiosis. And so he also was treated similarly. He had to ease into it because he couldn't handle 500. He kind of adapted how he did it. And he did a course for a couple of months. And again, he seemed to be doing great. So it was like 3 out of 3, it seemed. He later relapsed a couple of months later and he was retreated. But the point is, these are tough cases. These are well-documented cases. These are cases I could not stop treating them with antibiotics. And after the third case, my nurse Dawn and I, we were pinching ourselves. We couldn't believe it. And with that, I said, I have to write these cases up. So that led to the first publication. And meanwhile, so Monica, the time that I saw you at Parker, we had just we just were in the middle of these 3 cases, so we were very excited, but it was really premature for me to start recommending it to people, So that led to this publication, which issued May of 19, a year later. And I encourage people to read it. Since I was advocating using disulfram for treatment of Lyme, I felt obliged to scour through the literature and bring to people's attention the adverse effects that have been reported with disulfram. not having to do with Lyme, but just in general. I think anyone who may be using it prescribing it as a physician, any patient who's going to be on it, they need to be aware that this is a drug that, although it's generally pretty safe, it can sometimes have quite serious adverse effects, and people need to know about them. So amongst the most serious is liver injury. And sometimes that's idiosyncratic, like it's hard to predict. Of course, some of the patients who were on it had their livers very challenged anyway by alcohol use. But you don't want to miss that. And if there's an injury, you want to get them off it as soon as possible. And then there's various kinds of neurotoxicity that this drug can produce as well. And so anyway, I really scoured the literature, and I tried to bring forward many of the more important ones. And there is a vast literature, by the way, on disulfide. And also, it's not just for alcohol, it's not for Lyme. It's an amazing agent that has many different other uses. It's been repurposed for many other reasons. It's really fascinating. In fact, Dr. Rajadas had suggested to me it should be a candidate for what they call molecule of the year. There is such a thing in chemistry. But anyway, so with this experience, we began offering it to other patients, and over the next 3 years, and again, I want to emphasize, these are not just random patients. These are patients that they've been well characterized, they're well vetted, they're patients that I had a good handle on them. And that's an important thing to mention to anyone who might be prescribing this, and any patient who might be taking it. It's really important to have the patients well characterized, so you know what you're dealing with. Most of the patients in those first 3 patients, and most of the patients that we applied it over the next 3 years, which is total about 67 patients, they were all pretty well characterized. We had a pretty good handle on what they had, and that they'd already been around the block a number of times with more standard treatment. But of those, there were 71 patients, and this was not a study. This was an observational report. It was our experience as clinicians going back and trying to analyze, what the characteristics of these patients were, the ways in which we used disulfram, and the outcomes. So we look back, actually, very grateful to Xiaodi Gang and also Jason Gao. They helped us. Xiaodi is a MD PhD, and I'm functionally illiterate with all this advanced technology. Like I have to confess, which I have in multiple venues, I don't know how to do an Excel spreadsheet, but Xiaodi does. Like, she's a PhD, it's a piece of cake for her. So she helped enter all the data in an Excel spreadsheet, and then it made it much easier for us to analyze the cases. And it turned out we could break out the cases into 2 groups, a high dose group and a low dose group. And the high dose group were 4 milligram per kilogram per day or higher, and the low dose was less than 4 milligram per kilogram per day. And a lot of them a lot less than 4. A lot of them were less than 2 milligram per kilogram per day. Of the 67 patients, because we asked them, did you benefit from the disulfram? 92% of them, 92.5%, were able to say yes. They had a net benefit. Whatever the problems were, they felt that the disulfram improved their condition, which is pretty amazing, right? And then of the people who did the high dose, 36.4% of them who completed one, we had a few people who did more than one course of high dose, were able to enjoy what we're defining as, quote, enduring remission, meaning defined as clinically well for 6 months or more without further anti-infective treatment. So, again, in dealing with people who, would reliably relapse, it really got our attention. On the low dose, at the time that I was putting this together, I was saying that, I wasn't able to really know if people who used the low dose approach, whether any of those people were able to enjoy an enduring remission. But since I put this together, actually I asked Dawn, my nurse, to get in touch with one of our patients he's our record holder for the lowest dose ever, disulfram, and he did a quarter of a 250 milligram tablet, which is 62.5 milligrams once a week only for many, many months. And he was very sensitive. And I had Dawn get in touch with him recently. He's been off for quite some time. He's doing extremely well. So it seems that some people, even with a low dose approach, are able to enjoy an enduring benefit. And this is still ongoing, and we're all, I mean, I'm certainly continuing to learn what's the best way to use this agent. There were significant adverse reactions. Most of them were reversible when the drug was stopped, fortunately. Fatigue was very notable. A significant number of people had psychiatric symptoms of one kind or another, whether it was emotional lability, depression, anxiety. Quite a few folks experienced peripheral neuropathy, which it seemed really was from the disulfram and not the kind of neuropathy they were familiar with from their Lyme. In most cases, but not all, most cases that reverses when the drug is stopped. So, but you have to let people know, what the downside is of using this. And then as far as liver function tests, there were about 15% of people had liver function abnormalities. But again, fortunately, we picked them up early and they reversed once the drug was stopped. We didn't have any catastrophic liver injury. And I have to say, because this is new, we made sure that our patients had, fairly frequent lab monitoring. But I do have to say, and I'm not saying you shouldn't monitor patients, but, like 95% of those tests were normal. So if you think about it from that point of view, it's like, what a huge waste of money to do all this monitoring, but then you don't want to miss somebody with a liver injury. So, okay. So, so patients were treated from the low end of 6 weeks to greater than 16 months at the time this slide was produced. And some of them have been actually more than 2 years on the low dose. Let's see. Yeah, when I published this paper, a lot of people are still on ongoing treatment. So, okay. And then this is just a slide that indicates that there were much higher incidence of adverse effects on the high dose group than the low dose group. In fact, the low dose group was pretty mild, relatively low incidence of adverse effects. So, and again, many people seem to benefit even from the low dose. Ridiculously low doses. I still don't have that much data on can you do low dose stop and can people remain well. Then we had a certain number of our patients had both Lyme and Vibisiosis, some Babesia duncani, some Babesia microti. And that was surprising because many of the patients that we were dealing with, they required specific treatment for babesiosis, and a fair number of them, when they had been treated with disulfram, they didn't seem to require treatment for the babesiosis. So this was aimed at Lyme because I had no data about disulfram and Babesia, but somewhat surprisingly, it seemed to be somewhat effective. Then we also had another patient one of the patients who was in this group relapsed, and we were able to demonstrate that he had a positive Babesia fish despite having done disulfram. So it's a tool. And by the way, I've never claimed that disulfram is a cure, so I just don't know. But it certainly can be helpful, and it's just another tool, and it's not an antibiotic. Strictly speaking, it usually doesn't mess with people's microbiome. We don't even recommend that people take probiotics when they're on this. There was a certain number of patients who also had Bartonella. Some of them, because I told them, my patient, I don't know whether it does anything for Bartonella. So some patients wanted to just do the disulfram alone and see, how they did. And then some people were uncomfortable not treating their Bartonella. So some people we used disulfram as a monotherapy. Some people we combined, for example, with Zithro and rifampin or Minnow and rifampin. And it seemed that some of the patients, even without specific anti-Bartonella treatments, seemed to do well. But again, there's not that much data on it. I really can't say anything definitive about what disulfram does or doesn't do for Bartonella. I personally, I don't think I would count on that for treating Bartonella. Let's see. Yeah, as far as our current approach, like I said, select cases carefully. For me, these patients have been well characterized. And the patients who seem to be the most likely to benefit are those patients with Lyme who benefit from antibiotic treatment. In other words, they respond to antibiotic treatment, but then they relapse when you stop treating them, you treat them again. So those who are demonstrating that they have a degree of antibiotic responsiveness, those are the people that you would think would be likely to respond to disulfiram also. But we've also had a few patients who had very well documented Lyme. They got everything, the standard stuff. They got, IV ceftriaxone, didn't budge them, but they did seem to respond to disulfiram, curiously. So assuming it's a well-characterized patient, their lack of response to standard antimicrobial therapy, I would say, shouldn't necessarily rule out offering them a trial of disulfiram. I also want to say, I definitely would not recommend disulfiram out of the gate for patients, because it's definitely not standard of care. And just to remind all of us, some people respond well to standard treatment, maybe not standard according to IDSA or CDC, but I mean, a reasonable course of oral antibiotics of, number of months or whatever, or IV. Some people, remember, they stay well and they don't relapse. So I think, personally, I think people should at least, be given standard treatment before, you go on to disulfiram, which has some downsides to it. So, okay. We have a full discussion with the patient. Desirably, if there's a significant other, we'd like to involve the significant other, and that I have not felt that it's experimental, because it's off-label use of an FDA-approved drug, and that's within the discretion of treating physicians. So I have never required people to sign an informed consent. And I think, in a way, if you require them to sign an informed consent, that's tacit indication that you do regard it as experimental. Some of my colleagues do feel that they are more comfortable requiring people to sign an informed consent, and some of them do. And also want to point out that 3-4 years of experience with disulfiram, it's still a limited experience, and I think practitioners who use it and patients who use it should be aware. There's still a lot to learn about its use. Already said that. And of course, you have to let people know about the disulfiram ethanol reaction, and that can be severe, can even be life-threatening. So obviously, people have to be informed, and also, alcohol is sometimes hidden in things, over-the-counter things, and foodstuffs and whatnot. One of my patients, actually, was our case 3 in the original report. He went to a pub, but not to drink. He went to have shepherd's pie, and little did I know that shepherd's pie is made with Worcestershire sauce. And Worcestershire sauce has vinegar, which is partly fermented alcohol. And he had a not too bad, but he had nausea and vomiting and a little bit miserable, but it didn't last very long. And then I don't even know if this applies to human beings, but I joined one of the disulfiram Facebook groups just to learn. One of the people on the group dredged up this article from the literature of a mouse model where one of the breakdown products of disulfiram, diethyl dithiocarbamate, had been given to mice along with a component of green tea, epigallocatechin gallate, and it resulted in uniformly fatal liver injury in the mice. So that EGCG is a polyphenol. Many herbs have polyphenols. So I am not aware. I haven't heard any reports of bad things happening to patients who are on disulfiram who are taking herbs, but there's not that much literature about it. So I've usually discouraged patients from taking herbs while they're doing the disulfiram, just out of an abundance of caution. If anybody is aware of adverse occurrences because of something like this, I'd be interested to know. I haven't actually heard of a human case report, but and then, like I said, sometimes unanticipated interactions like the shepherd's pie. We usually get surveillance labs. I had been doing it weekly for the first 2 weeks, then every 2 weeks, and then I think that's maybe it's not a bad idea to do it every 2 weeks for the first month. Again, if there is liver injury, you don't want to wait to find out a month later, right? And then I think for most situations, monthly is adequate. Also, because this is novel, I have felt it was a good idea, and even though it's time consuming, I have a letter that's mostly boilerplate, but I have to adapt it, in which I make a point of sending a letter to all of the other practitioners involved in the patient's care so that they know what we're doing and why. Mainly because if there is an adverse effect, how would you feel if you were a primary and some wise guys putting your patient on disulfide, and then there's some serious problem and like you're supposed to pick up the pieces, right? Not very nice. So anyway, we routinely do this, and I think it's a good idea to do that. And then we've had generally follow-up monthly while the patients are on, and it's very desirable to have open lines of communication. And I'm a dinosaur, but actually I'm available 24/7, 365 to my patients, and I find the patients don't abuse it. I usually do a drug-drug interaction profile with the disulfide and other things, realizing that it may, those databases may not capture every adverse effect. And there's different ways of starting. And actually, I'm still trying to figure out what's the best way to use this. Those first 3 patients, I just socked it to them with a full dose. Generally, we've been starting with low doses and gradually increasing it, and because not everybody, most people can't handle 500 milligrams a day. It's just too intense because it can provoke very profound Herxheimer. But on the other hand, the upshot of that is some of the patients end up on disulfide for long periods of time, like 3 months, 6 months, 9 months, a year, even more than a year. And I'm getting to conclude that some of the toxicity, it's not just the dose, it's also the duration, a combination of dose and duration. And I did have calculus way back in the day, not that I remember much of it, but you can figure out, area under the curve, what's the total dosage that a person's been, exposed to. So I'm still not sure whether doing it gradually like that, working up to your target dose, and then once I get to target, once that somebody's at what I call target, like 4 to 5 milligrams per kilogram per day, generally I don't have them on it more than 6 to 12 weeks at maximum, and then I usually have them taper off. On the lower dose, I sometimes have people on much longer without a clear endpoint. And let's see. Yeah, so I'm beginning to wonder, maybe in some patients, if they can handle it, if they have adequate support and they're willing to experience it, it's just, give them their target dose from day one and realize they're going to be debilitated, make sure they have support. They're going to be maybe bed bound, or they need help getting from the bed to their commode, get it over with. And I just have the sneaking suspicion that there may be less neurotoxicity that way than dragging it out for 6 months, 9 months, a year or more. Even though you're trying to be compassionate and using cautious low doses that they can tolerate. But anyway, I'm still figuring it out. I'm not sure what the optimal regimen is. Now, getting back to that case, Vicki Logan case. It's a long story. I don't have time to really go into it, but if you really want to know what happened to Vicki, it's in my book, In the Crucible of Chronic Lyme Disease. Also, it's well detailed in my 42-page letter to Chris Gibson, who was my then U.S. Congressman. Did I send that to you, Monica, as a PDF? I forget what I did, but anyway, I can send it to you. If you don't want to buy my book, you can just read that letter, and it explains exactly what happened to her and why. Anyway, she ended up passing away, and she wanted other people to benefit from her case. And years later, she passed away in, I think, 2003. And it's a long story of what we had to go through for her tissues finally to be, to have an autopsy. It ended up being at Columbia Presbyterian by Jim Goldman. And so she had extensive tissues available. And Eva Shapi one day called me up and said, Ken, you wouldn't happen to have any tissues from a well-documented Lyme patient, would you? So I put her in touch with Jim Goldman, and he provided her with all kinds of tissues. And she studied them using her incredible techniques. And the bottom line was, in every tissue studied, heart, kidney, liver, brain, there was biofilm. And in the biofilm, there was convincing evidence of Borrelia by multiple methods, including whole genome sequencing. So it was really very, very bulletproof. So, and also, I don't know how much you folks know about biofilm, but these were large biofilm masses. Like every cut, if you use the right methods, and that's crucial, you have to use the right method. It was not hard to find these biofilm masses, and they were not small. They were 300 microns in diameter, some of them. Just bear in mind, a red blood cell, 5 microns. So, and also Eva has pointed out in her other publications that when bacteria exist within biofilm, they are 1,000-fold resistant to the action of antibiotics. So this may be at least one of probably multiple reasons why Borrelia are so, so persistent and resist antibiotics. This is from one of her earlier papers about biofilm. Amazing work that she did. And this is using a technique called atomic force microscopy, which demonstrates, this is in vitro, not in vivo, biofilm, which shows that it actually has a structure. It has pores. The organisms that reside within the biofilm have a metabolism. They require oxygen. They excrete CO2 and other waste products. That's the other thing. One of the breakdown products of disulfiram is something called carbon disulfide. Carbon disulfide is a very small molecule. It's of the order of carbon dioxide. And carbon dioxide diffuses in and out of biofilm. And I'm presuming that carbon disulfide diffuses in and out of biofilm. And they actually measured, carbon disulfide in patients on disulfiram, usually these are alcoholic patients. And it's present in nanograms per, nanomolar concentrations. I like to show this, showing that, carbon dioxide, well, oxygen and sulfur are like right above one another on the periodic table. The point that I'm making is carbon disulfide is also a very small molecule. And this is from Wikipedia. I didn't know what PM was until I looked it up. That's picometers. So the diameter of carbon dioxide and carbon disulfide is pretty close. So anyway, this is pure speculation. I really don't know if this is why disulfiram is active against Borrelia. And in fact, unless Dr. Rajadas knows, and maybe he does know, I'm not even sure if people know exactly what the mechanism is by which disulfiram, either the parent drug or one of its numerous metabolites, has activity against Borrelia. Okay, so I've talked about the promise. Let's talk about the perils. And there are perils. There's a whole series of articles that were put out by folks at the Vanderbilt. The lead author or the primary investigator is William Valentine, a vet and a PhD, and I've actually been in touch with him. Did beautiful work. And it seems like a lot of toxicity, well, carbon disulfide could be toxic too, but DEDC, one of the breakdown products, is very lipid soluble. And it also has a high avidity for metal ions, and in particular copper. And it's thought that the DEDC copper chelates migrates into peripheral nerves, but also into the central nervous system. And it's really thought to be the copper per se that damages the myelin. And this is not subtle. This is not, like theoretical. This is very real. This is in a rat model on the upper panels showing, normal sciatic nerve. And in the lower panels, it shows what happens to the myelin when it's exposed to DEDC copper. it really damages the myelin, and it also damages the Schwann cells that help to produce the myelin and protect the neurons. Again, usually this is reversible in patients, and of course these are very high doses in these rats. But so it indicates this is very real, and that's why. And also, I try to be a careful clinician, but it's not always easy to see the toxicity coming. You know, sometimes people are on these higher doses, they seem to be doing fine, and then rather abruptly they'll develop very severe symptoms of severe peripheral neuropathy. And of course, with that, you have to stop. Again, usually it subsides, although it can take sometimes months to subside, and it can be uncomfortable. So we try our best to avoid this if we can. But even for me, it's not so easy to know when you're approaching that point of toxicity. So, conclusion: disulfiram monotherapy is useful in the treatment of Lyme disease, perhaps Babesiosis, maybe Bartonella, but I really need a lot more data about Bartonella. It seems that if you want to try to secure an enduring remission, 4 to 5 milligram per kilogram per day from 6 to 12 weeks appears to be optimal, although sometimes we've gone to higher doses. But doses as low as, listen to this, 0.06 to 2 milligram per kilogram per day for indeterminate durations have also conferred benefit with relatively minimal adverse effects. Close follow-up is important, and in an individualized and flexible approach with shared decision-making is particularly suitable in the use of this agent. This is our team who got together in writing up that second article. And this is the team socially distanced. And I've given you a bunch of references, including a lot of references about the potential toxicities. And it's just, I don't think it's a panacea. It's just nice to have options. And I hope that we have more options to come, and I think we will have. And this is just one thing that came about. Why? Because patients, researchers acknowledge that chronic Lyme disease is real. Acknowledge a problem, you have a chance of solving it. Deny the problem, you'll never solve it. Thank you for your attention. And I guess I can entertain some questions now.
Okay.
Thank you so much.
Yeah, thank you. So our first question today, Dr. Ligner, is from Luke. And he said, you mentioned high dose provokes strong herx. How low would you dose if patient is very sensitive to herxing? What is your best treatment / management of herx?
It's usually going with very low doses. Like in a sensitive person, I might start with, for example, I know they can be compounded. You can make up the capsules of whatever strength you want, but we just generally, in most cases, just using the regular prescribed disulfiram, which comes in a 250 milligram tablet, which is easily halved, quartered, and probably you can even roughly do an eighth, which is like 31.25. It depends how sensitive they are, but you can finesse it and start with very, very low doses. I've heard some people starting with 31.25, once a week or twice a week or 3 times a week. And just like any, even with antibiotics, if you have a very sensitive person, you have to go very, very gingerly. I mean, there probably are other adjunctive things that could be done, which are sort of a little bit out of my domain. I'm not particularly trained in integrative therapy, but the different herbals that might be able to mitigate, the inflammation, turmeric and things like that. But generally, it's by using low dosage, and the least frequently that I've dosed it is once a week.
Okay, the next question is from Claire, and she's asking, is disulfiram effective for treating Morgellons?
I don't know the answer to that. I have not had there was one person with Morgellons that came to me, but she went back to her prior treating physician. So I don't really know. I'm not sure about that. I've heard that Ginger Savely is having some good results with ivermectin. I just don't know the answer to that. I would think that it might be helpful, but actually I don't have experience with it for that setting.
And then Claire also has a second question. What is your approach for biofilm busting? While I have documented reduction of biofilms with disulfiram, I still have elevated biofilms.
Well, the biofilm is created by the organisms that are resident, right? So to me, I would think the most effective thing is to, if you can eliminate the organisms, then they are what's creating the biofilm. Now, maybe there's other, biofilms can be polymicrobial, right? So there might be other resident flora that's not sensitive to disulfiram. And I know there's a lot of talk about, biofilm busters, so-called, but I haven't seen any really published studies about, so-called biofilm busters demonstrating what they're actually doing. So I don't know, but they're obviously they're very challenging, and again, we didn't even know about biofilm until a few years ago. I think I thought actually I was thinking that Alan McDonald was the first one who proposed biofilm, but I actually checked with him recently. He confirmed for me actually it was Eva Shapi first raised the possibility of biofilm, and she proved it that it really does happen.
Okay, and then we only have time for one more question from Lauren. She wants to know, are you still a fan of Cystis T?
I don't know what Cystis T is, so I can't, if she thinks I've been a fan of it, that's the first I've heard of it. Maybe she can tell us about Cystis T. I don't know what it is.
Okay. All right, and I think that was all for today for questions. Yeah, because we're out of time at this point.
Thank you for having invited me.
Thank you so much. We appreciate your time, Dr. Ligner.
You're very welcome.
Thank you, Dr. Ligner. It's great to have you back, and hopefully next time in person.
That's right. Maybe I'll get out to Red Rocks and
Absolutely.
stay for more than like 2 days or something in Colorado.
Yeah, definitely. Make some time to see more of the state. So
that'd be great.
thank you.
Thank you so much.
Yeah.
Sure.
So next we have Dr. Bruce Bono. Dr. Bruce Bono is also a pioneer in the field of Lyme disease. He's authored diagnostic hints and treatment guidelines for Lyme and other tick-borne diseases. He's a well-recognized specialist in the diagnosis and treatment of Lyme disease and associated complex infectious diseases and the chronic illnesses that accompany them. With over 35 years of research in this field, he has appeared in and on virtually every form of media, both in the US and abroad. He has testified before the US Senate and Armed Services Joint Subcommittee and at various governors' consulates. He is also a founding member of ILADS and ILADS Educational Foundation. And with that, Dr. Bruce Bono will be talking about, and forgive me, I lost my note. His title today. Oh my goodness. I had it right here. I know you're going to be talking about testing.
That's good enough. That's fine.
Testing in the world of tick-borne diseases, and I am looking forward to it so much. I just don't have the exact title in front of my face. So
well, that's fine. Thank you very much.
You're welcome, Dr. Bruce Bono.
Well, let me share my screen. Here we go. And we'll make it big. There we go. Ha! So there's the title. How do you like that? I want to talk about, see, you weren't that far off. I'm just going to talk about advancements in laboratory testing. And, it's sponsored by Igenix, and they asked me to do this. And it's fine. I don't work for them, but they have me do their speeches from time to time. And the reason why I said yes, besides wanting to connect with you, because I heard good things about you from a lot of people. And as an aside, I love Colorado. I've been there several times. I would love to go back. But anyway, several new things have come in the field of testing. And in fact, one of the tests I'm going to talk about today is brand new. You'll be probably the first group in the country to hear about this. So how do you like that? It has to do with a whole new testing technology that's kind of revolutionized many, many things in testing for tick-borne diseases. And interestingly, they're applying that now to COVID-19. So the two big things that we are dealing with as Lyme docs is, of course, Lyme disease and the tick-borne diseases with it, and now COVID too. And they kind of overlap, as you probably expect. So I'm kind of anxious to show you this new information. We'll start with the tick-borne diseases, and I wanted to talk about how using a better lab, and specifically better lab tests, can really prevent a lot of problems. Now that sounds kind of obvious, but it's not just the problems of finding good diagnosis, because we always say, you know, tick-borne diseases are a clinical diagnosis. You can have Lyme with a negative blood test and so forth and so on, and that's very true. But on the other hand, you know, in the real world, if you're a physician and you're treating a patient with seronegative Lyme, you know, the testing is negative, but you're convinced to have it based on clinical diagnosis, you can face trouble and criticism, and you as patients too, from family, from other practitioners. The insurance companies start getting involved. They're not going to cover treatment or testing if the test is negative. And then you all have heard of the medical boards coming after doctors who have treated Lyme aggressively. And so because of that, a lot of doctors and other practitioners are kind of reluctant to treat patients who have a negative blood test. So is the answer to not treat the sick patients? Of course not. The answer is to find a better test and a better lab. So now, good question to ask as well, are the tests really that bad? Truthfully, some of them are. I'm going to use Lyme disease as a specific example. I'm going to give you kind of a lot of detail, and I like giving detail because first of all, I'm kind of a nerd with this stuff. But also I think in general, the more you understand something, the better off you're going to be able to help yourself and to share the word with people who care. So we'll start with showing you how bad the ELISA is. This is a study that was actually published maybe 10 or so years ago. What they did, they took together a number of different studies that are published on how sensitive the standard ELISA is. And the standard ELISA showed a range of sensitivity from as little as 29% to as much as 75%. And then the table you see, I can have my arrow show this. Oh, I'm going back one. This column is sensitivity, and it's 66, 55, 50. Here's the 75. The column here is specificity. There's a trade-off in an ELISA. The more sensitive it is, the less specific it becomes. So here, the one that's 75% sensitive, the specificity dropped to 81. So in other words, 20% of the time, 19% of the time, these people showed positive for Lyme. They didn't have Lyme. That's something else. So this has been well published. And what the author did was he added this up and made an average. So the average sensitivity is 49%. He calls it a coin toss. And that's kind of unfortunate. I'm laughing, but that's really unfortunate. You would never diagnose another illness with a 50-50 test. So now in the wisdom of the CDC, they've come up with this thing called the two-tier test. The idea is you start with a very, very sensitive first test to really not miss anybody. But then if it's positive, you do a second test. It's very, very specific. That way you'll filter out these false positives. Okay, so it's what the two-tier test is all about. But there are a lot of problems with this. In the world of Lyme disease, they chose the ELISA as their first tier. Well, that's not a very sensitive test. It's a very insensitive test. So right away, you're filtering out half the cases. Now, the problem is, even if you have a positive ELISA and you do the second tier, you're going to find only...
Welcome to a via IP office.
That we're getting a call. You can hear me? Okay. The problem is that the Western blot as a second tier is not much more sensitive than ELISA. It's also not much more specific either. So you really have a test that misses a lot of people. Now, there's another subtlety to this, which I'll talk about. Why are they so insensitive? This is the big news. It's because these tests, these ELISAs, are built to detect a laboratory strain of Lyme disease. They call it lab strain B31. That lab strain, number one, was never from a human being. It came from a tick sample. So number one, it's not even a human infection, never tasted human blood. The second thing is, it's been known for decades now that when you take a Lyme germ, a Borrelia germ, and you put it in culture, which is what they do, and they keep this thing growing in incubators for the last decades, 20, 30 years, they lose some of their genetic material and they become less like the actual infection that people get in the real world. So with that in mind, the genetics lab took a large group of patients who were seronegative on commercial Western blots, but were diagnosed nevertheless as having Lyme disease. Clinically, they had the symptoms of Lyme. And what they did was they used a new technology that they developed using recombinant antigens. I'll show you what that is in a second. The test that incorporates these things is called an Immunoblot. So the beauty of the Immunoblot is that they have engineered it to detect not just this one lab strain, B31, but all the different Borrelia that can cause infection in humans. So they took these group of patients, this one series, 36 of them from a single physician's practice here in North America. These are all seronegative by the Western blot. But guess what they did? They found all these tests were positive on the Immunoblot. And what did they have? They didn't have Burgdorferi B31. They had these other species. Borrelia mayonii, Spilmanii, Californiensis, Greenii, Afzelii. Greenii and Afzelii are the European species that are supposed to not exist in America, but here they found them. They found Valesiana. They found one case of B31, so that was missed by the Western blot, and some others that could not be speciated. What that means is that they were positive tests. They just couldn't tell which species it was. And the reason why that is, two things. One is most likely and most commonly that there are more than one species present. So you can have a co-infection with different Borrelia. The other reasons could be that other Borrelia are present that can't be detected or are detected but can't be identified with this type of technology. So that was one big deal. Second big deal, which is even bigger deal, is another case they did. These are 48 cases from another physician's office who were seronegative on the Lyme Western blot, and they didn't have Lyme at all. They had relapsing fever. Different kind of relapsing fevers. There's louse-borne from lice and tick-borne, and tick-borne is what we have to deal with mainly in America. And they found these patients, 48 cases who were seronegative for Lyme disease, had Borrelia for the relapsing fever Borrelia. They had Hermsii, Miyamotoi, Turicate, Tusicalike, and 26 others, Parkeri and others that they were not able to speciate. But the point is that, number one, these people thought to have Lyme disease, were seronegative on Lyme tests, but were sick and in fact were infected with Borrelia. Second point, which is a really important thing, especially if you in Colorado, a lot of your doctors are familiar with relapsing fever because it is endemic in Colorado. But if you look at a textbook, the textbook says that relapsing fever is very different from Lyme disease. It's an infection that starts within a short time after the bite. The person gets a very high fever, shaking, terrible chills, really sick, 102, 103, even 104 fever. And it persists for a day or so. Then it ends in what they call a crisis with terrible sweats, low blood pressure, you're bedbound. So this whole thing resolves. And then guess what? For the next 4 to 7 days, you feel fine. But then the name relapsing fever, the whole thing starts again. And you have these cycles of relapses separated by feeling better. The problem, though, is that what is this series showing you? It's showing you that these are people thought to have Lyme disease, not relapsing fever. So this dramatic presentation, high fevers and sweats and crises and good and bad, that's apparently a very small minority of the real cases of relapsing fever. So it's kind of like I say, it's like in Lyme disease. How many people get a Bell's palsy? Hardly any. So maybe the tick-borne relapsing fever Borrelia did not read that textbook, and they actually are presenting in a lot of people, and maybe the majority of people, like Lyme disease. So very big takeaway is that if you're seronegative, it may not be that it's a bad laboratory or the wrong test, but you're doing a test for the wrong species. So why is that important? Well, none of the big labs, like the commercial labs that we all are using, none of them with their IFAs, their ELISAs, the Western blots, the PCRs or the T-cell tests, none of them have been validated for any Borrelia other than that B31. And none of them have been validated for tick-borne relapsing fever. Now, if you go to a big lab and you want to test serologically for tick-borne relapsing fever, they're going to give you one, and that's Borrelia hermsii. And they use a very old-fashioned IFA technology, which isn't very sensitive. You can separately order for B. miyamotoi, but with miyamotoi, they're using what's called the single antigen to test for it. I'm getting ahead of myself, but if you know about a Western blot, what they do is they look for a number of different bands, and the bands on the Western blot are all the different antigens, and you have to have a number of them before you call it a positive test. Well, this is calling it positive with one antigen only, meaning that it's going to be very insensitive and probably not so specific. All right, so what's happened is what we call the recombinant revolution. In other words, making tests that use recombinant antigens. Recombinant antigens increase the sensitivity and specificity, and they offer this extended coverage of different species that I described. So IGeneX is offering this for Lyme disease with all the multiple species I showed you, for tick-borne relapsing fever likewise. And today I'm showing you information on their Bartonella immunoblot. As I said, this is new. You're the first group of people to hear about this because it's just now been released. They're also doing this for COVID-19, and that's why I wanted to include that in today's presentation. They also offer what's called a broad coverage assay. You know, the Immunoblot is going to just get rid of the Western blot. There's no reason to do a Western blot nowadays for one species when you can do an Immunoblot for all of them. But likewise, you're not going to do an ELISA anymore because they have this broad coverage assay, which is the same multi-species recombinant type of test, but it's made very, very simple to make it cost effective and more affordable for those who don't have coverage. And so this is a simple yes or no answer, and they have IgM and IgG put into it. So if you do this test, it just says, yes, you have something, or no, you don't. And you can do this for Lyme, and you can also do it for tick-borne relapsing fever. So these are the two new tests for Lyme using recombinant antigens. Now I'm going to go into more detail. This is my nerdism coming on. So bear with me on this. This is a picture of a Western blot. These are what are called the bands that show different antigens. So how's a Western blot made? And this is what makes it different from an Immunoblot. To make a Western blot, you have to get Borrelia growing in a culture in a test tube somewhere. And after they've grown to a certain amount, you take them out and you break them apart into a million little pieces, you sonicate them, and you extract these antigens. So number one is that the quality of the culture will dictate how well these antigens show up on a Western blot. And again, on a Western blot, this picture, these black horizontal lines, all the different antigens. Okay, so if in other words, you have a very heavily growing culture, you're going to have a very dark, dense band on the Western blot, and maybe you're going to get too many bands and get some false positives. Likewise, if the culture is very poor, what may happen is that you don't get enough bands. You get very poor antigen production. And the third problem is that poorly grown cultures sometimes make atypical antigens, and you get these weird bands on the Western blot that may make them less sensitive. Now, so they collect these antigens from broken up spirochetes, and what do? They put them on little strips of filter paper, and they subject them to electrical charge. Now, these antigens that are put on there, they put a little drop in the beginning, and they put electrical charge, and they migrate. They start at the top, and they migrate down based on their electrical charge and by their molecular weight. So the ones with the high molecular weight, the high numbers here, don't migrate so much because they're big and heavy. The ones with smaller molecular weights, they migrate further. And that's how they spread out over this Western blot. Where they end up lines up with what they are. For example, this column here, column 8, that's the control. So here you have what are called the bands on the Western blot. Here's band 41. You find that in pretty much many spirochetes. So the idea is to put the electrical charge in this thing and let the thing spread out until they line up with this control thing. Well, that's so imprecise. I mean, God, it's like last century technology. So not only is the density of these blots, these dots, these bands dependent on the quality of the culture and from a lab strain, not from a real patient strain. Second thing is where they end up, the migration is prone to a lot of uncertainty and falsities. Now, just look at these. These dark ones here with my arrow, if you can see it, that you're going to call that a positive. What about these finer ones toward the top? How dark do they have to be called a positive? It's a very subjective test. The other thing is that there's some bands on these Western blots that are very specific. Like band 41, you find them in most all spirochetes, including things that aren't Lyme disease. Band 39 is very specific for Lyme. This one has it, this one has it, this and this. But there are other bands that are non-specific, like these bands here, like 17 and 60. They're not very specific for Lyme disease. So a lot of uncertainty here. Now let me go to what's you see in an Immunoblot. What is a recombinant antigen? What they do is they take the genetic material of the spirochete that makes these antigens, and they use them to engineer and produce very precise, highly purified antigen. So it's not dependent on how good a culture is. It's specifically grown and engineered in the test tube. What they do is they use a printing method to deliver to their strip very precise amounts. So you're not worried about a culture strong or weak. It's a dark blot. It's a weak one, a light one. It's exact amount. And they're also delivered by the printer to exact specific locations. So this is so much cleaner, so much more exact. And because they're selecting which bands they're going to be putting on this, there's no non-specific bands. All bands here mean something. So just to drive the point home completely, compare the Western blot on the left to the Immunoblot on the right. I mean, look at this band 8, this lane 8. I mean, it's such a smudge. I don't know if that's a medical term, But look at how it is on the Immunoblot. It's so much more clear. It's like a whole revolution in testing. All right, so how more accurate is it? Well, when they specified or tested specificity, I should say, there's a lot of different samples. They get them from CDC, from commercial labs, from internal labs, from other places. And they found that if they use their own criteria, the specificity is between 97 and 99%. If they use a very strict CDC criteria, it's 99 to 100%. So it's very, very specific. You're not going to find this cross-reacting, for example, with someone who has lupus or someone who has some other infection. Now, the sensitivity is also very interesting. This was validated with CDC samples, test samples. CDC sends to the lab unmarked test tubes of blood, and it's up to the lab to kind of figure it out. And their samples include early Lyme as well as late Lyme. And their definition of early Lyme is someone who's presented with an EM rash and has a rash at the time the blood is taken. Well, what they found, and this is really a game changer, is that in early Lyme, CDC cases of early Lyme, where people had EM rash, when you look at either IgM or IgG, one or both were positive 93% of the time. So this is a whole game changer. It's a whole new paradigm. We've all been taught from day number one that in early Lyme, time of EM rash, someone comes in early. Don't even waste your time doing a blood test because it's too early for it to show up. Well, this completely changes that. You have a test that 93% of the time will pick it up. Now, it's so important because a lot of time people don't get a rash. They might have been exposed to ticks or know they were near ticks, and they come in with a like a summer flu that feel not well. So you think, all right, what is it? Do you have sinusitis? Did you pick up COVID? Do you have something else going on? We don't know. So do you suspect Lyme and give them antibiotics? Do you not suspect Lyme and see what happens? Do you wait a month and do the test then? Now that uncertainty is gone. Another problem, what if someone comes in with an atypical looking rash? Well, it could be Lyme, could be ringworm, a spider bite, a cellulitis, poison ivy. I mean, here you don't have to worry about it. You can take a test, and because it's basically a serologic test, the turnaround time is really pretty quick. So never before has there ever been a test that's this accurate for early Lyme disease. It's completely changed the whole thing. And later Lyme, when they checked it using CDC samples, 100% of the cases of CDC late Lyme was picked up. So again, this is a total game changer using this kind of recombinant technology in the Immunoblot. Another thing to know about is there are other tests for Lyme, of course. There's the PCR, the T-cell assays, the antigen assays, the urine and spinal fluid antigen assays, and even the new one called NanoTrap. Important though, now that you know that there's a lot more Borrelia out there than just this B31 lab strain, it's important that if you're going to have these tests done, you make sure it's at a lab that will do a PCR or a T-cell test or the others in a broad, extended way that will pick up all these other species. Now in IGeneX, for example, the PCR is genus level. So it's genus Borrelia, species is Burgdorferi. So they do what's called the genus level test. So all the Borrelia get picked up. So this way you're much more likely to get a positive test. They say, all right, is that just too broad? Well, no, the specificity has been calculated to be 99.9%. So it's less than 1 in 1,000 chance of it being a false positive. The T-cell response assays likewise can be broad or narrow. At IGeneX, of course, they use a genus level to make it broad. Their specificity and sensitivity is about 80%, so that's really not too bad. They offer the antigen assay. It's a urine test or a spinal fluid test. It's multi-species, multiple antigens. So again, it's very broad. A new test that's out, not by IGeneX, is called the NanoTrap. It's also a urine test, claims very high degree of accuracy, but if you look into the data, they're looking for one antigen, not all those different ones on the Western blot or the Immunoblot, and if only Lyme Borrelia, not all the other broader species of Lyme. So it's not offering broad species coverage, and it's not offering even broad antigen coverage. So the risk here is have a lot of false negatives. So in testing for tick-borne relapsing fever, again, the big lab serologies, if you ask for relapsing fever, you can get Borrelia hermsii, and that's it. It's an IFA. They don't publish the accuracy, so who knows? It's just we know that IFAs are not very accurate tests. Miyamoto, you can ask for that separately. Again, it's the ELISA, but just to that one antigen. Remember the Western blot had all those different bands you have to look for. This is just one, so the sensitivity is not too great. On the other hand, if you do the Immunoblot, because it's recombinant, it's 97% sensitive, 97% specific, able to do multiple species. Likewise, they're multi-species PCR. Now get this, the way you rate the sensitivity of PCR is how many germs do you have to have before it shows positive. So they rate this as what's called the limit of detection. How many germs per ml of blood? So I went to the literature on the bigger labs, the big commercial labs, and one of them publishes a limit of detection for relapsing fever PCR is 5,000 germs per ml. Another lab, they claim it's 125,000 germs you have to have before it will be shown. IGeneX, the limit of detection is less than 100. So it's thousands of times more sensitive than these commercial labs. And one of the reasons why is if you send your blood off to IGeneX for a PCR, what they do is they do 4 separate PCRs automatically. They do it on whole blood and they do it on serum because sometimes the germs are there in one and not in the other. And when they do it, they do 2 different types of PCR in each sample. They look at the genomic DNA and the plasmid DNA, and that is why they get more sensitive. You know, it sounds like a commercial for IGeneX, but the thing is, we always use IGeneX, and I'm just happy to go into the details and find out why is it that it's such a good lab. Now, here's another thing. Obviously, it's not just Lyme disease, it's co-infection. They published a study in 2018 of over 10,000 patient samples from all the states across the country. They found Babesia, Lyme Borrelia, relapsing fever Borrelia, Bartonella, Anaplasma, Rickettsia, Ehrlichia. 40% of these tests, 40% of the 10,000 had 2 pathogens. 15% had 3, 4, even 5 were found. So co-infections are not a rarity. They're very common, almost half the cases. So let's go through them one at a time. Bartonella is a very, very difficult pathogen for the clinician and patient alike. First of all, it can cause a lot of disease. Second of all, the symptoms overlap with everything else. And third thing, and importantly, it's very hard to detect it. You know, in practice, we've been doing every test we can for Bartonella and hope to find something that can document what's going on. And the reason why is that they can live in the bloodstream, but they also can live in the tissues, and they also can live inside the cells. So where they are at any one moment is hard to know and therefore hard to detect. When they are in the blood, the bacteremia level is very low, and it varies from day to day and even hour to hour. And finally, just like Borrelia, they make biofilm. In fact, they are really major at building biofilm, even more so, I think, than Lyme. And I show some incredible videos of Bartonella biofilms in the bloodstream. And these were like big masses of gelatin. Embedded in them were blood cells and the Bartonella. And so these big blobs are running through the bloodstream, no doubt plugging capillaries and causing some of the symptoms of Bartonella. But also, when Bartonella is in, or any organism is in the biofilm, not only is it hard to treat, but it's also hard to test for. A PCR is not going to penetrate a biofilm. The immune cells are maybe not going to pick up the cells that are hidden inside the biofilm. So even serologies are insensitive. Another thing about Bartonella, there are many, many species. We talk about multiple species with Lyme. Bartonella has at least 30, and some people think as many as 50 different species that potentially can infect us. So here again, if you go to a lab and ask for a big lab, say, I want a Bartonella test, they do cat scratch disease, Bartonella henselae. That's like 1 out of 30 that can cause illness. So that's why there's such difficulty in detecting them. So today we're introducing the Bartonella Immunoblot from IGeneX. Again, it's multi-species. It uses recombinant antigens and can detect almost all the relevant species that can infect humans. Now, if they have a positive test, they will actually try and speciate them, and they can show you if it's one of these 4, Lisbethae, Henselae, Quintana, Vidsonii. So if one of those or more of those, because co-infections are common, are present, they'll name it. Otherwise, they'll just say it's positive. We found, you know, one of these other species. And beautifully, it's available in IgM and IgG, so you can tell the date of the infection and how active it is. It's also very specific. In looking for cross-reactivity, they tested in blood with Borrelia, did not cross-react with relapsing fever and Borrelia, relapsing fever, and anaplasma, Borrelia and anaplasma. I mean, the whole list of different things they tried, and even 12 separate controls other than these things like autoimmune diseases, other infections, and so forth. And there's no cross-reactivity at all. Other Bartonella testing, the FISH test. I don't know if you know about the FISH test for Bartonella, because that's fairly new. It's known to be the most sensitive direct test available for Bartonella. And the reason why is 2 things. One is it's a test that looks for the RNA of the organism, not the DNA. It's an RNA test. RNA disappears as soon as the infection is killed within minutes. So a positive FISH test means you have living active infection at the time the blood was drawn. Other thing, and this is, again, what's really key, is FISH is a technology that will detect organisms embedded in biofilms. The first papers on this came out years ago, in 1990s. They've started publishing how you can use this technology for biofilm detection. And again, it's genus specific, so it has all these different species you can get. That's why it's the most sensitive one. And I talked to a practitioner last night who said that of all the tests they do, they're always negative until they get to FISH, then it's positive. But they didn't have the new Immunoblot, so we'll see how that goes. Another new test that's out there is a droplet digital PCR. It's a urine test. It's a blood test through Galaxy Labs. Here it detects DNA, not RNA. So you may not know that this is an active infection at the time because DNA can linger afterwards. It also may not detect Bartonella and biofilms. It's never been tested or reported for that. The way the test works is they drop up the sample into, or they divide it up into very teeny weeny droplets in the size of nanometers. And I don't think that'll be able to, you can't do that with the biofilm. It's too rigid. So I don't know if it's going to detect the biofilm Borrelia. I just don't know. And finally, they offer now at Lyme and tick-borne disease in general have impaired B cell function. It's one of the reasons why they become seronegative. Here, you can have a T cell test if you have a B cell problem. All right, so the recommendations, as good as these tests are, it's still hard to pick up Bartonella. So what you need to do is use two different types of technology: a direct test like a FISH or PCR, and an indirect one. Here, the Immunoblot by far is the best. If you have someone who has a B cell dysfunction, immunosuppression, then you're going to add to that the T cell test as well. So you can do the Immunoblot for the B cell, the Bartonella FISH for the direct test, and the T cell test if necessary. Now we'll talk about Babesia. The two main ones are Duncana and Microti. Others are occasionally found. Now, I know from looking at lab reports that there are others that are in humans. We can't talk about that legally because these tests have to be licensed and so forth, but I'm telling you, they're out there. Now, these germs can be found throughout the entire United States, not just the West Coast. I mentioned that because Duncana was called WA1 because it was thought to be in Washington state only. That's not true. We find actually more on the East Coast than on the West Coast. So if you can do a Babesia test, you want to be able to pick up all these different ones. And I guess, again, most labs don't do that. They either detect one species or they say they detect multiple, but they don't. So here again, we have the FISH. Detecting RNA means that positive means you have an active infection at the time. It's not showing you might have had it 10 years ago. If it's positive, now it's there. The way they do it is they take a sample of your blood, they make a slide out of it and look under the microscope. And the stain they use is an RNA-specific probe that attaches to the RNA of the living Babesia. So you're actually seeing it with your own eyes. You can photograph it and there it is. So it's not one of these vague indirect tests that might mean you had it in the past. The FISH again is by genus, not species. So it's going to detect more than just one species. And on validation testing in one of the states, it scored 100%. So that's really pretty good. Again, a PCR has to be genus specific. Not all labs do that. And we're going to do a serology. You want to do separate ones for Microta and Duncana to be sure you're picking up both. An Immunoblot is under development for this, and hopefully that'll be out soon because we certainly need it. All right, we're going to switch gears and talk about COVID-19. We're going to talk about the new ways that the new tests are going to help us not only in diagnosis, but in management and decisions about vaccine. So here we go. First of all, we know the PCR test, the swab test, is really very insensitive. In other words, you can have COVID and not show it. And this is a report from a study published in Annals of Internal Medicine about a year ago. Day one of infection, which is before the symptoms happen, none of them showed it, 100% false negative. On day 4, which is the day before their patients had symptoms, 67%, 2/3 had a negative test. On the day of symptom onset, still 38% had a negative test. Only by day 8 and 9 of infection does the test peak, and only at 20% false negative. So in other words, you're picking up 80%, but you're not picking up the last 20. So their conclusion is that clinical suspicion is high. You can't rule it out based on a negative swab PCR. So that's pretty poor. Now about the antibody testing, well, that still is problematic. Again, false positives. You can have a positive serologic test for COVID and never having had COVID. And why is that? Well, at least 40%, 45% of the common colds are caused by mild coronaviruses, and sometimes the serologic tests for COVID pick them up. So you get these false positives. Now, what about the false negatives? Well, because these types of tests are serologies, there's a trade-off between sensitivity and specificity. You get a lot of positives, but then at the risk of a lot of false negatives. So what they do, they turn down the sensitivity of the test to give you less false positives, but then you get a lot of false negatives. So again, we're stuck in that bind, and the new technology that we've talked about already is Immunoblot. So Immunoblot for the virus that causes COVID is SARS-CoV-2. The Immunoblot looks for the antigens to that. And they're, again, recombinant antigens. They're specifically created in the laboratory to be very, very precise. So because of this, you don't have the cross-reactivity problem you have with other coronaviruses. Much more sensitive, much more specific. And as you can see on the bottom, when you look at both IgM and IgG, the sensitivity is 94%, much, much higher than the other serologies. And the specificity is between 98 and 99%. Now, if you look at the picture, you can see the different bands on the Immunoblot, and look at what they're looking at. C1 and C2, that's controls, where they have S1, S2, N, and RBD. That's spike protein 1, spike protein 2, the nucleocapsid protein from the virus, and the RBD, the receptor binding domain on the spike protein of the virus. So what that means is, by individually testing for this different spike and nucleocapsid proteins, you can distinguish whether a positive test is coming from a natural infection that someone had or from having had the vaccine. The reason why is because the vaccines in America give us antibodies to spike 1, sometimes spike 2, and sometimes the RBD, but they never do for the N, because N is the nucleocapsid. It's part of the body of the virus. It's not part of the spike. So if you've had a vaccine, you can have antibodies to one of the spikes or both of them and the RBD, but you're not going to have antibodies to the nucleocapsid because it's not component to these vaccines. So that's how you can tell by an Immunoblot. Not only is it a more sensitive test, a more specific test, but gives you a lot more information. It's very, very helpful. Another thing that we know, not everybody develops a good B cell response, a good antibody response to COVID. In fact, we'll go back a few spaces. Let's see. Here's the graph. The blue line and the orange line here reflect how much virus is in the system. The dotted lines reflect antibodies. The antibodies never get to 100%. They never get there because some people who have, going the wrong way, who have COVID, they don't have a strong enough immune response, and that's apparently where a lot of them get sick. So the other thing you look for is the T cells. So until now, there's never been a really good T cell test for the reactivity to the infection with COVID. And so now IGeneX came out with one that uses what's called the ELISpot technology. What that means, it's a functional assay. If it's positive, it means your T cells are active right now to the presence of the virus. So it's reflecting active immunity. In other words, it doesn't reflect having had COVID in the past. It means that the germ is probably active, the virus is active at the time the blood test was taken. And because of that, unlike serologies, it does revert to negative once the infection has cleared up. So here we have, with the Immunoblot, a way of testing our immune response overall and whether it's been to an active infection, a natural infection, or to the vaccine, or both. And also now we have the T cell test that can help tell us how active the thing is right now. So again, the application clinically, the Immunoblot's a more reliable marker of past exposure than the simple serologies out there now. It's also now able to distinguish whether the antibodies are from a natural infection or from the vaccine. By combining the two, you have a much more complete picture. So when do you do this? Well, after you've had COVID, do you need to get the vaccine? Do you have still immunity? Can you go out and see people? I've had COVID in the past, am I now immune? Well, instead of guessing and maybe being risky, you can just do a test now or a couple of tests and find out what's going on. What about someone saying, I'm kind of reluctant to get the vaccine. I had a cold early on and maybe I had COVID, maybe I already have antibodies, maybe I don't want a vaccine, I don't need a vaccine. Well, here, don't guess. You do a test, find out if you can get by without the vaccine or if you actually do need it. Likewise, what's been found is that people who get the vaccine can still sometimes get COVID. And what's been found in the research using Immunoblot is that a lot of people, after having the vaccine, won't develop a very strong antibody response, or if they do, it may not last that long. Everyone's different. It's a very broad spread. So here you can see After someone's had the vaccine, you wait several weeks and you can take a blood test and see if they actually had a good response. Likewise, now I had the vaccine already. I had it back in January. I'm starting getting to the point where, well, is it wearing off? And they're talking about needing booster shots in the fall. Well, do I need a booster shot? Do I still have antibodies? Rather than guess, you can do this. Another application, which I don't have on this slide, let's say you're a Lyme patient, right? And you decide to get the vaccine, but your Lyme symptoms are pretty active. And because of that, when you got the vaccine, the first dose, you had a really strong reaction to it. Now you're scared. You say, I don't want to have this happen again on the second dose. Do I need a second dose? Well, instead of guessing, again, do the Immunoblot, do the T-cell test, see if your body is responding to the vaccination. And if it is, then you can hold off on the second dose until things calm down, retest and then see if it's needed. Or if on the other hand, you find you don't have good antibodies, then you can do the second dose. So a lot of use of this, that doors really opened up. Now, post-COVID syndrome, a lot of talk about this. How come the symptoms are just like those in chronic Lyme? Maybe post-COVID is people who had tick-borne disease, either they knew about or didn't know about, and the infection of having COVID now activated this. They got reactivated tick-borne diseases. So could that be? Well, there are many similarities clinically in terms of the symptoms, but also there are some differences too. So the way you figure this out is by going through the list, and we're going to do that. Part number one is symptoms. Many of the chronic symptoms are common to both, but the differences have to do with organ damage. Is there organ damage? How much? And where is it? What organ? Now, list of symptoms common to both, okay? Common to COVID, post-COVID, common to chronic Lyme, tick-borne diseases. There's fatigue, headaches, the arthralgias, myalgias, the cognitive deficits, the sleep difficulties, palpitations, rapid pulse, familiar to a lot of you. Also, you can get sweats and chills, shortness of breath, the cough and dizziness, conjunctivitis, GI upset, anxiety, depression. All these are recognized things that can happen in chronic tick-borne disease, chronic Lyme, as well as in post-COVID long hauler type things. But you know what? I did a clever thing here. I do say so myself. Column one, first column, fatigue, headache, arthralgia. Those are things that we commonly associate with active Lyme Borrelia type infections. The middle column, the sweats, chills, the shortness of breath, the cough, the dizziness, very common in Babesia. These are things we think of with Babesiosis. And finally, the last one, conjunctivitis, GI, and anxiety, depression, comes with Bartonella. So thinking about someone coming to you with post-COVID and says, I've got fatigue, I've got body aches, I'm short of breath, I'm coughing, a little bit dizzy, my stomach's upset, I'm really anxious. Yeah, it could be post-COVID, but it also could be tick-borne diseases that have become reactivated. So you see, that's where the confusion comes. So how do you differentiate it? Well, in chronic tick-borne diseases, chronic Lyme, there's often a history of at least exposure, if not actual Lyme disease that you've had in the past. And here's the key. The symptoms in Lyme typically are migratory and cyclic. In other words, you have a neuropathy affecting one part of your leg and then it switches to your arm and then to a different leg and it moves around. Likewise, joints can be knees and then becomes ankles and moves around. That's classic for tick-borne disease, symptoms that migrate and symptoms that cycle. I've been saying this for decades now. If you keep a daily diary, you'll see that Lyme symptoms get better and worse and better and worse in a 4-week cycle. You have good days and you have bad days, and they seem to map out to every 4 weeks. That doesn't happen in post-COVID. Likewise, in tick-borne disease, you do the testing, try and see if something's going on, and using testing like PCRs and FISH, you can look for active infection. Likewise, the T-cell testing. With chronic COVID, obviously you have to have a history of prior COVID by definition, or at least exposure where you think you could have had it. Here, the symptoms are constant. They don't migrate or cycle. Yes, you can have good and bad days, but usually it's pretty steady. But here the difference is in long-term COVID, there's end organ damage, kidney failure. You don't often see that, rarely see that in Lyme disease. Low blood oxygen level, again, not something common to Lyme disease. Blood clots, you've heard a lot about the blood clots. That again is very unusual in a tick-borne Lyme type disease. Of course, the confusion is someone could have both. You could have had COVID and had tick-borne diseases. The COVID reactivated the tick-borne diseases because that means your immune system is down, the COVID could persist. So it's not one or the other, it could be both. So how you evaluate? Testing for the infections. Do indirect testing and direct testing like I described before, because that helps you to evaluate someone who might have immune deficiency or dysfunction from the infections. If you can do serology, you can definitely want the Immunoblot. Add to that a T-cell assay, and if it's available, PCR on fish, because those are the direct tests that will help to see if something is there. And we're talking about, tick-borne disease and COVID as well. And then you want to look for the specific damage that you see with COVID and not with Lyme. Blood oxygen level. You can do a little thing on the finger. You can do a blood test for it. Chest X-ray, we're looking for the scarring that comes with COVID involving the lungs, kidney function problems, and so forth. Very large number of people who have had COVID, even mild COVID, have evidence of it on a cardiac MRI. I read a recent study where they evaluated the hearts of young college athletes who all had COVID. It was mild, they just quarantined, they got over it, and that's fine, and they wanted to go back to playing their sports. Well, they did heart MRIs, cardiac MRIs on all of them. And believe it or not, 40%, actually it was 42%, had abnormalities on the MRI showing the heart was inflamed or had swelling or some damage. So it's a common problem, even with very mild COVID, and it could be a sensitive test to do to look for the evidence of COVID, but it's also something you may want to do to know if there's some heart problem going on. I mean, you don't want to be the person like the athlete who drops dead on the court, playing basketball. I mean, it's a tragic thing, but these are people who have unknown or undetected heart problems. So one of the things I'm having my recommendations on COVID evaluations to include a cardiac MRI. Now, sometimes lung involvement from infections, COVID, others, will cause a kind of damage that doesn't bother when you're at rest, but when you exercise, then you don't keep up. In other words, it impairs oxygen transfer across the membranes. So putting that little thing on your finger or getting a blood test for oxygen when you're sitting there may not be sensitive enough. You may have to do what's called a pulmonary stress test, where they have you exercise and measure oxygen levels during exercise. If the oxygen levels go down, that's a sign that the lungs are not transmitting the oxygen across the membranes. So what about COVID and Lyme? Let's say you have Lyme disease and you're worried about getting COVID. Well, there's good news. First of all, many of the antibiotics used in Lyme are also antiviral. The tetracyclines, the macrolides, azoles. Are they strong enough antiviral to stop COVID? Well, probably not, but they might be helpful. Also, most treatments for Babesia are antiviral. Those that are based on quinine or artemisia, those are known to be antiviral agents, plus the macrolides that come with them. Azole antifungals like diflucan, that's an azole antifungal. They seem to be antiviral. And of course, the complementary treatments used in Lyme, many of them are antiviral and help the immune system. So there are a lot of things that's just built into Lyme treatments in general. And I say Lyme, I'm including the whole spectrum of tick-borne disease, that may be protective against a bad case of COVID. And the more good news is that actually I've surveyed several different practices of Lyme literate physicians who have seen a lot of COVID patients. And without exception, they've all said that very few of their Lyme patients got COVID, and those few who did, the COVID was very mild, much more mild than you would expect. So, of course, Lyme literate doctors are often COVID literate, and they will be prescribing antivirals like ivermectin, giving them zinc and vitamin C and D and glutathione and the other things we know are very important for COVID. So, for whatever reason, if you're seeing a Lyme literate doctor and you have Lyme and you're worried about COVID, yes, you should worry about it, but it may not be as bad as you think, because there's still risk factors. They found age over 70, 75, it starts to really increase the risk. If you have active cancer, God forbid, that really increases the risk. I don't know if it's from the cancer or from the treatment, it's probably from either one. Obesity is there as a risk. They took away diabetes and hypertension because in more studies they found unless it's really out of control, it's really not a separate risk factor. But obviously if you're on immune suppressive treatments, because of autoimmune disease or cancers, that's a risk factor for COVID. And because very advanced late stage Lyme can involve immune deficiency, that is another obvious factor to look for and to consider. You can do testing for immune competence in the Lyme patient. You can measure antibody levels, you can measure T cell reactivity, just as a way of measuring your immune competence. So the suggestions with Lyme and if you get COVID, one is to avoid strong Herxheimer's if exposed to the COVID, because you don't want to have COVID during a Herxheimer. Herxheimer is when your body's the most stressed and least likely to defend itself. So if there's exposure, you may have to back off the treatments, the antibiotic treatments, just to minimize any Herxheimers that are happening. No harm in putting yourself on the vitamin D, the C, the zinc, melatonin, NAC, alpha-lipoic, and especially glutathione. These are commonly used supplements in Lyme disease. They're very commonly used and almost universally used by those who know in COVID, and there's no harm in putting them in the mix. if you get COVID-19, then you definitely want to add glutathione because it gets rapidly depleted, and depleted glutathione makes the infection worse. Another thing is mitochondrial support, the B vitamins, the membrane support, all the other things that the advanced Lyme doctors are offering because they help your immune system. You need strong mitochondria to have strong white cells, and you need strong white cells for a good, strong immune system. So keeping your mitochondria happy is important. And then the basics, healthy diet. Don't go out on an alcoholic bender. That's not allowed. Enforced rest. Do not let yourself get run down overtired. Make sure you're getting good sleep. If you can't sleep well, get to a physician to prescribe something, because sleeping is when your immune system recharges itself and heals. So poor sleep is bad. And then, the fears and anxieties also impair immunity. It's bad enough to have chronic Lyme and chronic tick-borne diseases. That's a fearful and anxious promoting situation to be in. Bartonella can actually add to the anxiety, as can the others. Now, on top of it comes COVID, comes the restrictions, the lack of mingling with your friends and family. That's really, really hard on a lot of people. So counseling, meditation, exercises, all the different things that can help with that are important to add. So I'm going to end by talking about the vaccine. Now, should you, if you have Lyme, get the vaccine? Well, people who don't have Lyme, who have good immune systems, usually do have a reaction to the vaccine, especially after the second dose. I certainly did. So everyone has some kind of a reaction. About 30% have a really strong reaction. I was one of them. I had, chills and a fever, and I had to stay in bed for a day. Couldn't eat my ice cream. Can you believe it or not? Fever, chills, weakness, fatigue, body aches. But these usually last a day and a half, 2 days. Rarely does it last more than 3 days. I talked to Dr. Richard Horowitz yesterday, and he doesn't have anyone in his practice who had a prolonged bad reaction to the vaccine, even the second dose. I will tell you, though, that if you have had a vaccine and you've had a long-term reaction that's bad, you have to think that maybe it's reactivated your tick-borne diseases or something like that. So really, yes, you can have a reaction, but it's not a long-term thing that should be scary. If you have active infection and active symptoms from your Lyme, you're going to, odds on, have a more strong reaction to the vaccine, especially the second dose. That's why I said earlier in talking about the testing for the Immunoblot, if you've had active Lyme, you have an active Lyme, and you're getting the vaccine, and after the first dose, you have a strong reaction, you say, I'm not going to take a second, or do you need a second? Test yourself, see if you need it. Now, all that being said, if you had such a bad reaction to a simple vaccine, think of how badly you'd react to the actual infection. So I'm among the group who actually do advocate for the vaccine. I've done a lot of work with vaccine. I was actually on the task force as an advisor to the task force last year for a short period of time. So I have a lot of background in that. And I have to tell you that, at least with the mRNA vaccines, I really strongly support them. And, it's a matter of preparing yourself for vaccination. Don't do it during a Herxheimer reaction. Make sure you're in the best of health. Get the vitamins on board, especially the glutathione. Hydrate yourself. All the basic things. Get your Lyme doctor on board before you do it. But again, if you're worried about getting a fever and some aches for 3 or 4 days, or 2 or 3 days from the vaccine, it'd be a lot worse if you get the actual COVID. So please get the vaccine. So the recommendations: test for the COVID virus by Immunoblot and by the T-cell test, IgG spot, before vaccination to make sure you didn't have a past infection, because if you already had the infection and you still have antibodies to it, don't get the vaccine, you don't need it. And if that's the situation, you can't stop the immunosuppressant, then that's when you want to get the vaccine and test afterwards to make sure that it worked for you. And again, if you react strongly to the first dose, you may want to be tested by the Immunoblot before getting the second dose, because you may not need it right away. You may want to hold off a little bit longer. In the UK, the second dose is given routinely 6 to 8 weeks after the first. They don't do that here because people can get COVID after the first shot because it's not 100%. In the UK, they were doing it to prolong or to extend their vaccine supply because they don't have as much vaccine as they want. Anyway, if you do cancel the second dose, then do the immune tests on a serial basis every few weeks. And when the vaccine response lessens from that first dose and the tests show that you're not immune anymore, then you can get the second dose with less likely to have a side effect from it. But also at that point, you definitely need it. So we're closing. The final thoughts. Lyme and tick-borne diseases are bad enough, and now we have this stupid COVID to deal with. But as always, the more you know, the better off you're going to be. So keep abreast of everything that's new and relevant. Insist on the best science and take advantage of the latest technology. And of course, please stay safe. So that's it for me today. Let me sign out of this. I'm going to close this one down. All right. All right, stop the screen share.
Thank you very
Are
much.
we ready for Q&A?
Yeah, thank you. And now we have some time for some questions.
All right, so we have one question that came in from Lauren. She wants to know, even with 2 doses of the vaccine, whoops, hang on a minute.
Well, you're
Okay.
still there, I can hear you.
Lyme patients have a more increased risk of contracting COVID versus others when referencing the ever-changing CDC guidelines.
There was an internal study done at IGeneX where they took a large group of people who were tested for antibodies before and after the vaccine, as well as after COVID. And they found that the immune response is incredibly variable. There are people who had strong vaccine response and good immunity that lasted for months and months and months, others where it lasted only a short period of time. And some people who didn't even have Lyme had a very poor response and really weren't immune. So what works for one doesn't always work for anyone else. So rather than guess, I would say get the Immunoblot test, because that's a test that shows your status in terms of immunity.
Okay, and let's see. I have a question actually for me. I'd like to know, on a toddler, if you suspect that a toddler could have Lyme via in utero, and she has some strange symptoms, what age would you recommend testing a toddler for Lyme?
Well, you know, the interesting thing is you can do a urine test for Lyme by using the IGeneX antigen test or PCR from them or anyone else, because number one, it's really easy to get urine from a kid, much easier than getting blood. And also, in a very young patient, their blood antibodies reflect out of the mother for the first 6 months or so. So an antibody test in someone very young is not going to be that accurate. But in a toddler, once they're beyond age 6 months, the antibodies that they form are their own antibodies. The problem, though, is as we develop from fetus to newborn and on up, things that we're born with, our immune system does not always recognize and fight off. That's how we don't reject our own organs, for example. That's how come the mother doesn't reject the baby through the placenta. So it's a matter of the immune system becoming tolerant to what the baby has when it's born. And that's a long-winded way of saying that the babies are often seronegative, even toddlers. So you really need to start to do the direct tests. You do the FISH tests, you do the PCRs, you do the antigen capture tests. You probably should do an Immunoblot as well, because it is the most accurate test out there and it's going to pick up things that other tests don't. So the answer to that question is after age 6 months, an immune-based test like an Immunoblot is fine. And at any age, a urine-based test is really simple and a good thing to do. Now, just know that spillage of Lyme in the urine is intermittent. So the routine is to do 3 different urine tests and you send each one into the lab. You can put them all together and send them all at once, but you always want to do 3. The more symptomatic the person is at the time, the more likely the test is to show. So if the person's having good and bad days, take it on the bad day. If they're going antibiotics and have a Herxheimer, during the Herxheimer, they spill more antigen into the urine. So that's when you do the testing. But again, at a toddler, you can do it.
We have time for one more question. This one is from Claire, and this question is, what is your recommendation for Babesia testing? Fish and what else? Especially for picking up multiple species of Babesia. Same question for Bartonella.
For both of them, I'll tell you the same thing. In practice, I've never found any one test to pick up everything. I've had people who are FISH positive, but serology and PCR negative, PCR positive and FISH and serology negative. So if it's affordable, I always do all three for both of those things. I do the serology. In the case of Bartonella, it's going to be an Immunoblot. I do the PCR and I do the FISH.
I think that is all that we have for now. Thank you very much.
Oh, you're welcome. I'm happy to do it. It was fun. I wish I were there rather than, electronic, but at least I get to wear my Hawaiian shirt.
We wish you were here too.
Thank you very much.
Yeah, I'm so appreciative of your time, Dr. Broscano, as well as Dr. Ligner's time with us today. And thank you so much for joining us. For everybody that's on, if you have not already registered, you can register for our day 2, where we'll be hosting retired Colonel Nicole Malachowski as she shares hope and inspiration in the face of Lyme disease with her talk on harnessing headwinds. So if you haven't registered already, there is still time to register for that. We'll be reconvening tomorrow morning, 11 a.m. Mountain Time. We appreciate everybody that joined us today. And if you have any questions, please reach out to us. And you can find us at all these various locations, our website, Facebook, Twitter, Instagram, for both COTBD-AA, as well as the Colorado Lyme and Tick-Borne Disease Support Group. So thank you very much, everyone.
Ciao, ciao.
Thank you.
Thank you, everybody. Bye-bye.
Good talk.